in the next few minutes, we will talk on stroke, cerebrovascular diseases. It's a very good slide showing the ischemic stroke, hemorrhage, both intracerebral and subarachnoid. See the ischemic stroke area. Here the clot occluding the artery, more common, about 85% of the people. Intracerebral hemorrhage, bleeding into the brain, about 10%. And subarachnoid hemorrhage, bleeding around the brain, 5%. But in my experience, maybe subarachnoid hemorrhage maybe 1 to 2%. Intracerebral hemorrhage maybe 10 to 12%. And these strokes, ischemic strokes, up to 80 to 85%. See, this is an important slide. Here are the three areas. One is the normal area, ischemic area, that is the penumbra area, then the infarct, that is the necrotic area. See the penumbra. So this penumbra is much bigger than the true infarct area. So infarct area is a very small, surrounding area is the penumbra area. Suppose if you keep the blood pressure, if you reduce the blood pressure very effectively in all these acute thrombotic strokes, so what will happen? The blood supply to this penumbra area will be reduced, and this penumbra area is much more increase in its size, and the infarct area is also increasing its size. So we are giving more harm to the patient. By keeping the blood pressure higher, maybe at the systolic beyond 160 or 170, and the diastolic beyond 100 or 110. So you are flowing, you are making the blood to enter into this penumbra area, so that the ischemic zone will be reduced and the recovery will be very good. So if you see the normal blood supply here, 50 ml for 100 grams per minute, whereas in the penumbra area, it is up to 8 to 23 ml per 100 grams per minute. In the infarct area, less than 8 ml for 100 grams per minute. See the acute infarction and subacute infarction. Acute infarction 4 hours. So subtle blurring of the grey and white junction and the sulcal effacement. So just blurring of this grey and white junction is seen in the initial few hours of the infarct. So that is the reason. So initial few hours of the infarct, if you get a CT scan, we may not appreciate the changes. But see the subacute infarction with the 4 days or after 12 hours or after 1 day. So definitely there will be the obvious dark changes and the mass effect. So the ventricle compression is also seen. It is pushed to the opposite side. So this is an ischemic stroke. See, this is the hemorrhage. So in the left side, you have the cerebral hemorrhage. On the right side, cerebellar hemorrhage. So in the posterior brain, cerebellar hemorrhage in the posterior brain. So cerebral hemorrhage is in the midbrain. Here the subarachnoid hemorrhage. If you find the 4 pictures here, first picture A, there is the axial brain CT scan, shows the bilateral frontoparietal sulcal subarachnoid hemorrhage. In the B, you have the axial FLIR image, confirms the subarachnoid hemorrhage, white arrowheads. In the C, lateral projection of the 3D MRA shows multiple arterial stenosis and dilatations. And the picture D, lateral projection of a right internal carotid angiogram shows the multiple stenosis and the dilatations of both anterior cerebral and the middle cerebral arteries. So blood pressure levels in the stroke suggested by the current guidelines: primary prophylaxis, acute ischemic stroke, secondary prophylaxis, acute hemorrhagic stroke. So let us concentrate on the prophylaxis, both the primary and the secondary. In the primary prophylaxis, patients with hypertension should be treated with an antihypertensive drugs to a target BP of less than 140/90. Even 130/80 is also advisable. That is the primary prophylaxis. So if the patient happens to be an hypertensive, keep the blood pressure as close to the normal as possible to prevent the further multi-organ damages. That is primary prophylaxis. What is secondary prophylaxis? Here the BP therapy is indicated for previously untreated patients with ischemic stroke or TIA who after the first several days have an established BP of more than 140 or the diastolic more than 90. So in the secondary prophylaxis already is in hypertension with TIA or the established stroke. So what about the goals? Goals for the treatment target are uncertain and should be individualized. So depending on the comorbidities, age, etc. It is reasonable to achieve a systolic pressure less than 140 and the diastolic less than 90. So in the secondary prophylaxis, use an antihypertensive and your goal is less than 140 by 90. For patients with a recent lacunar stroke, a systolic BP of less than 130 might be reasonable to target. So that depends on the person. Suppose if the person is young individual, is tolerating the blood pressure, so he's not getting any giddiness or etc. hypotension symptoms. So even you can reach the target of your 120 by 80 also. So that is secondary prophylaxis. What about the acute ischemic stroke? See patients with elevated BP who are eligible for treatment with IV alteplase, that is the mechanical thrombectomy, should have their BP carefully lowered to a systolic BP of less than 185 and the diastolic of less than 110 before IV fibrinolytic therapy is initiated. Now when the fellow comes to the hospital with a window period of say 3 hours or 6 hours, now the window period extends up to the 6 hours. So they are ideal candidates to go for the TPA therapy. In patients not treated with IV thrombolytic therapy, for whom intra-arterial therapy is planned, it is reasonable to maintain the BP less than 185 110 before the procedure. So that is an acute ischemic stroke. Now the antiplatelet thrombolytic therapy is also available. Now we have the interventional neurologists or interventional radiologists. These two people are responsible for this fibrinolytic therapy, IV fibrinolytic therapy. What about the acute hemorrhagic stroke? In patients with the systolic BP 150 to 220 and without contraindication to acute BP treatment, acute lowering of systolic BP to 140 is safe. So in hemorrhagic strokes, reduce the blood pressure. So systolic to 140. Whereas in ischemic stroke, keep the blood pressure at higher level. In patients presenting with the systolic BP more than 220, it may be reasonable to consider the aggressive reduction of the BP with the continuous IV infusion and frequent monitoring and again reach the systolic BP of 140. So that is acute hemorrhagic stroke. So pathophysiology and the blood pressure targets according to the ischemic stroke mechanisms. So high blood pressure, so there will be the fibrinoid necrosis, occlusion, small vessel disease. Target for the secondary prevention, systolic blood pressure less than 130, reduces the cerebral hemorrhage. Intracranial atherosclerosis, high blood pressure. So there will be the oxidative stress, increase the inflammation, endothelial injury, plaque formation, increase the medial mass, and progression of the atherosclerosis. So targets for the secondary prevention, here see the systolic blood pressure less than 130 by 80 to reduce the cerebral hemorrhage. Systolic blood pressure less than 140 by 90 to reduce the ischemic stroke recurrence. So these are trials. So VASID trial and stable ICS trial. So they say that less than 140 by 90 is ideal. See the TPA, IV TPA, and the B is the endovascular treatment. C is the acute phase general. C IV TPA, before the IV TPA, the systolic blood pressure 185, diastolic 110 within 1 hour. During and for 24 hours after TPA, so reduced to 185 and 105. Endovascular treatment, during for 24 hours after endovascular treatment to reduce to 185 by 105. If failed reperfusion, systolic more than 150, see, this is for this, not for the common people. So this is only for these tertiary care centers. So where you have the facilities of interventional neurologists or interventional radiologists available. So they give this thrombolytic therapy, and then within 3 to 4 hours they discharge the patient, and dramatic response will be seen in this population. So the BP management is hemorrhagic stroke, intracellular hemorrhage and subarachnoid hemorrhage. What about the intracellular hemorrhage? For patients with intracellular hemorrhage with systolic blood pressure between 150 and 220 without the contraindications, acute lowering of the systolic to 140 is generally safe. Reducing systolic blood pressure below 140 in the first hours after onset may increase the risk of renal adverse events. So in all the ICE, intracerebral hemorrhages, when the systolic blood pressure is between 150 and 220, so lower the blood pressure, systolic blood pressure to 140 is relatively safe. If you reduce to less than the 140 systolic blood pressure, so there may be a risk of renal adverse events. Suppose if the patient's blood pressure is more than 220, so it may be reasonable to consider the aggressive reduction of the BP with a continuous IV infusion. Again, control of the BP variability may be useful. So to prevent of the recurrent strokes, BP management for target BP of less than 130 by 80 is recommended when the patient is medically and neurologically stable. So that is intracellular hemorrhage. Here the 3 points you should remember. When the fellow is presented with a systolic blood pressure between 150 to 220, so your target is 140. Suppose if the pressure presents with the BP of more than 220 with hemorrhage, so aggressive reduction of the BP with the IV infusions, and then reduce the blood pressure as rapidly as possible. And then for the prevention of the recurrent strokes, so keep the blood pressure at 130 by 80. What of the subarachnoid hemorrhage? Between the time of the subarachnoid hemorrhage onset and aneurysm obliteration, BP should be controlled with a titrable agent to balance the risk of the stroke, hypertension related rebleeding, and the maintenance of the systolic blood pressure less than 160 is recommended until the surgical clipping or the coiling. So these two procedures will be done by neurosurgeons. So surgical clipping or the coiling. For the prevention of the rebleeding, maintenance of the mean arterial pressure above 90 is considered to maintain the CPP. CPP, the cerebral perfusion pressure. Here 60-year-old gentleman woke up in the morning with a speech disturbance. So he got dysarthria. He is an hypertensive last 10 years. He is an amlodipine 5 milligrams OD. Smoker, 20 cigarettes per day. He is an alcoholic, 30 units of the alcohol per week. So heart sounds are the normal and chest is clear. ECG left ventricular hypertrophy. See the right arm. Systolic 167, 169, etc. Diastolic more than 90. So what is the initial management of the plan? So management of the stroke. So he's having dysarthria. So get the CT scan done. Management of hypertension suspected acute stroke. Urgent referral to the secondary care, CT brain, or urgent reduction of the BP. So which statements with regard to this initial management plan except CT brain is very much needed, but urgent reduction of the BP is not needed here. See the infarct. Darkness. Here 70-year-old gentleman is brought to your clinic by his family members with complaints of the worsening of the mobility and the drowsiness. Past medical history none. He is a non-smoker. He has nystagmus and ataxia. So nystagmus and ataxia are the features of the cerebellar dysfunction. Heart sounds are heard. Chest is clear. ECG again shows the left ventricular hypertrophy. See earlier case, left ventricular hypertrophy. This case is also left ventricular hypertrophy. So that is the reason in all the hypertensive individuals, at least once in a year, get an ECG done to rule out any left ventricular hypertrophy is there or not. If the left ventricular hypertrophy is there, that is an independent risk factor to cause the cardiac problems or the neurological problems. Here the right arm nearly 200 and the systolic and the diastolic is 97, 96. Fundus shows hypertensive changes. So how would you manage this patient? See, this is the hemorrhage in the cerebellum area. So urgent referral to the secondary care. CT brain is important. So manage the BP because it's an hemorrhage. So you have to reduce the blood pressure as quickly as possible. Otherwise, you can increase the further hemorrhage in these individuals. So that is the reason we need the CT brain, immediate CT brain in all our severe patients. 1.5 for your patient here.